Hello, everyone. I'd like to welcome you to this first in a lengthy webinar series about self-management support in British Columbia. And we're going to start now with some introductions and let you know a little bit more about the GoToWebinar platform. This will be a little bit different system than we sometimes use for webinars. So again, my name is Connie Davis. I'm one of the co-directors of the Center for Collaboration, Motivation, and Innovation, which is a nonprofit based in British Columbia. Today's webinar is about stepped care self-management support. This webinar is made possible with the support of Patients as Partners, an initiative of the Ministry of Health, Province of British Columbia. I'd like to introduce Danielle Wiebe, who will walk you through the features of GoToWebinar.
Hi, everyone. Thanks for joining today. I just want to talk about a few of the different features of GoToWebinar before we get started. So right now you're looking at a slide of what you should see on your screen. And so it should show you webinar housekeeping, and on your left-hand side you'll see the presentation. On the right-hand side you will see your control panel. So I'm going to tell you a little bit about the control panel and what to expect there. When you're not using it, it'll collapse automatically, and to keep it open, you can click the View menu and uncheck Auto Hide Control Panel. All right, next slide. So if you're looking closely at the control panel, you will see that there's different ways to participate. You can submit comments or questions to the presenters, and these are going to be anonymous, so only Connie and myself will see those, and we'll be able to answer you in text, but otherwise you will be muted during the presentation. All right, I think we can look at the next slide. During the presentation, you can raise your hand if you want to voice a question, but I think we'll be saving all the questions until the question and answer period at the end. And I can mute and unmute you when you want to ask a question, or you can type your questions into the question box, and I can ask them on your behalf if you prefer to remain anonymous. Today's presentation is going to be recorded, and we'll be putting it on CCMI's website. You'll receive a link to the web page when it's ready, and you will also receive an email with username and password so that you can log in. This is going to be a secure website. At this point, I'm going to turn it back to Connie. If you have questions throughout, go ahead and use that question box, and I'll be keeping an eye on that throughout the presentation.
Thank you very much, Danielle. As Danielle said, this presentation is going to be recorded, so because of that, it's going to be a bit more didactic than you may be used to on a webinar, but we do welcome your questions, and we'll be looking forward to addressing those in the question and answer period. So first of all, I'd like to go over the objectives. There are 4 objectives for this presentation. The first one is to define self-management and self-management support. I'm going to explain the steps in the step care model and the associated self-management interventions. We're going to be describing the link between the 5 priorities in British Columbia and self-management support, and describe the evidence for self-management support. Here you see the Ministry of Health's 5 strategic areas of focus, and in this webinar, it's part of the work of the overall improvement in the quality and sustainability of the BC health system. These quality improvements are both in experience of care and in better health. The focus is to work across all of those who are involved in healthcare in these 5 areas, and they are improving access to primary care through a primary care home model, to reduce demand on hospitals by improving care for seniors, to reduce demand on hospitals by improving care for those with mental illness and substance use issues, to improve access to surgical services and procedures, and to improve the delivery of rural health services. In this presentation, we'll describe the step care approach to self-management support and show how concepts from self-management support are useful for all of the ministry's priorities. The Province of British Columbia also emphasizes the triple aim. The triple aim represents a balance of care that's really important for improvement efforts. And those three balanced outcomes for improvement are a better experience of care, both for professionals and people receiving services, better health, so better outcomes, healthy people, at a sustainable cost. So often throughout this webinar, I'll be referring to this triple aim: a better experience of care, better health, at a sustainable cost. Another aspect of care that's laid out in policy documents in the British Columbia is patient-centered care. And there's a document called a Patient-Centered Care Framework, where the ministry says that patient-centered care puts patients at the forefront of their health care and ensures that they retain control over their own choices, helps them make informed decisions, and supports a partnership between individuals, family, and healthcare services providers. When we talk about patient-centered care, we need to also incorporate the family and caregivers as a separate entity in themselves, and also as how their contribution helps in the healthcare system. So patient and family-centered care contributes to the goals of the triple aim, and many aspects of self-management support are seen here in the definition of patient-centered care in BC. But to look at these 5 priorities in the triple aim and patient and family-centered care, it's probably really helpful to think about a situation. And so I'm going to introduce you to an example that we'll be referring to throughout this webinar. Mr. Frank Jones is a 77-year-old man with diagnoses of diabetes, hypertension, macular degeneration, chronic obstructive pulmonary disease, and heart failure. There are also concerns about his memory, but there's no diagnosis. Mr. Jones lives with his wife, Doris, who's his primary caregiver. Mr. Jones has been unable to drive for 2 years due to his vision, and Mrs. Jones has never driven, so they are dependent on public transportation and friends and neighbors. They have a son who's married, but he lives 2.5 hours away and is not often available to assist them. Over the past 3 months, Mr. Jones has been hospitalized 3 times for uncontrolled diabetes or heart failure exacerbations. According to his last hospitalization, he was admitted with a blood sugar of 30.5 millimoles per liter. His treatment included an insulin drip as well as changes to his injectable insulin. During his hospitalization, Mr. Jones was noted to be withdrawn, and a depression screen was positive. Mrs. Jones states she's taking over more and more responsibilities around their home, such as managing their finances and arranging appointments. She says she wants to do all she can for her husband, but admits to being a little overwhelmed. They've become socially isolated since they do not drive, and have strongly expressed the desire to remain in their own home. Mr. and Mrs. Jones may be very familiar to you. This situation has become an increasing concern in healthcare as systems organize themselves to address the needs of people and families, achieve better outcomes and quality of life at a sustainable cost. Throughout the presentation, we'll be using several terms, including the first one here, self-management. This first definition is a plain language definition. Self-management is simply what all of us do every day. We make decisions and we take actions that can protect our health and improve our well-being. And as you can see, this definition is based on a publication by Gantz in 1990. This definition of self-management is from the healthcare literature, and it's written by several people, with Adams being the lead writer, and it's one of the most often cited definitions. It's the one that is used in the BC publication Self-Management Support, a Healthcare Intervention, which was published in 2011. They've written that self-management relates to the tasks that an individual must undertake to live well with one or more chronic conditions. These tasks include gaining confidence to deal with medical management, role management, and emotional management. So this definition talks about self-management as tasks and states that the goal is to gain confidence to manage them. These 3 tasks of chronic illness self-management were first described by Corbin and Strauss in 1988 in their book, Unending Work and Care, Managing Chronic Illness at Home. Corbin and Strauss interviewed people living with chronic illness, and in their qualitative study, they were able to group what the patient said into these 3 tasks. We're going to look at each in more detail. The first task is called medical management. It's a familiar topic to healthcare professionals. So this includes activities such as obtaining and taking medication, monitoring symptoms or physiologic measures like blood sugar or blood pressure. It includes things like attending appointments or maybe making changes to weight, thinking about eating habits and physical activity. So medical management is the first task that the patients talked about in the Corbin and Strauss's study. The second task they talked about, they called role management. This means how you carry out your normal activities and maintain life roles, such as job, school and play, home, family, and voluntary work. A newly diagnosed person might be wondering how they'll manage working night shift with diabetes, or how they'll play soccer and keep their asthma in control. So how do I carry out my normal life now that I have a chronic condition? The third task is emotional management. This means dealing with the emotional impact of a diagnosis of a chronic condition. It could be anger, fear or depression, frustration, ambivalence, thoughts about a changed future, and the diagnosis can also change a person's relationship with others. Thinking back on our case study, Mr. and Mrs. Jones are facing health challenges due to multiple chronic conditions. There are medical management tasks, such as managing the insulin and the blood sugar monitoring, as well as the follow-up appointments. Mr. Jones is retired from work outside the home, but his physical health and functional status have made it difficult for him to manage his role within the household. This has increased the responsibilities on Mrs. Jones. His memory loss may also be playing a part and requires further exploration. The chronic conditions have also led to some emotional challenges, and they've expressed their desire to remain at home, and additional supports at home could help them do this. Mrs. Jones also needs attention to her own health and as a caregiver. She's providing many kinds of assistance to Mr. Jones, and efforts to support her benefits not only the couple, but also professional caregivers and the system as a whole. So remembering these three tasks, medical management, role management, and emotional management, can be helpful during a single encounter as a reminder for the clinician to address all three, and it also can help prompt the system as a whole to provide care that addresses all three of the roles. This actually takes us to the next term we need to define, which is self-management support. Here again is a definition from Adams and colleagues. Self-management support can be defined as the systematic provision of education and supportive interventions by healthcare staff to increase patients' skills and confidence in managing their health problems. So if self-management defines what patients do or people do, then self-management support is what others do. This is a definition that's included in the BC document. Here is another view of self-management support. This is from Dr. Tom Bodenheimer, who's written about the needs of people with chronic conditions, and he made these additional observations about self-management support. He wrote that self-management support is the assistance caregivers give patients with chronic disease in order to encourage daily decisions that improve health-related behaviors and clinical outcomes. Self-management support can be viewed in two ways: as a portfolio of techniques and tools that help patients choose healthy behaviors, and a fundamental transformation of the patient-caregiver relationship into a collaborative partnership. So he's expanded the view here. Now, as you can see, the terms self-management and self-management support often refer to chronic conditions, and some people use the term as self-care to describe more activities that people do on their own or maybe preventive behaviors. But you will see that self-management and self-management support are often used to define health promotion and health prevention behaviors as well. Now, when Dr. Bodenheimer talks about this transformation, let's just look at that in a little more detail. So self-management usually refers to how people take care of those chronic or ongoing health problems. And so the transformation Bodenheimer and his colleagues were writing about, it's partially due to the difference between an acute condition, such as a broken arm or an infection like appendicitis or a sore throat, and chronic conditions like diabetes, high blood pressure, dementia, depression, and arthritis. The healthcare system and the way we interact develop to treat acute conditions. So just as a reminder, acute conditions have a rapid onset and a short duration. They typically have one cause, and the diagnosis is generally straightforward, and diagnostic tests are often conclusive. Cure is the expected outcome. With chronic conditions, there's a gradual onset and lifelong duration. diagnosis may be uncertain, especially in the early stages, and in some cases, diagnostic tests do not exist or are not as helpful. Cure is rare. This information is from Dr. Kate Lorig and her colleagues, and it's covered in the book, Living a Healthy Life with Chronic Conditions. This is part of the information and skills shared in the self-management education workshops provided by the University of Victoria Institute on Aging and Lifelong Health. People living in British Columbia can participate in these workshops, both in person and online. Because of the ongoing nature of chronic conditions, the roles professionals and patients play are also different. In acute illness, the professional selects and conducts the treatment, and the patient, maybe along with their family caregivers, follows the treatment plan, participating in decision-making if there are different options to choose from. In chronic illness care, the professional is a teacher, a coach, and a partner, working with the person who is the daily manager of their illness, along with their caregivers. As described earlier when discussing patient and family-centered care, the person with the condition makes informed decisions about the options available to them to manage their condition. This transformation to self-management support, as described by Bodenheimer, is reflected in the transition from acute care style of interaction to the collaboration needed for chronic illness care. One approach to help people with chronic conditions is patient education. This table contrasts patient education with self-management education. Self-management education refers to educational programs or approaches that are tailored to addressing the three tasks of self-management support: medical management, role management, and emotional management. Both patient education and self-management education are necessary, but they're different. Let's compare the two. In patient education, information and skills are taught. The topics are determined by healthcare professionals. In self-management education, skills are taught to solve patient and family-identified problems. Patient education is usually disease-specific. Self-management education has generalizable skills. Patient education assumes that knowledge creates behavior change, and self-management education assumes that confidence yields better outcomes. In patient education, the goal is compliance. The goal is increased self-efficacy in self-management education. Teachers are the healthcare professionals in patient education, and teachers can be professionals or peers in self-management education. Many organizations have transitioned their patient education to encompass self-management education so that it can help people put their knowledge into action. And some workshops, such as those offered by the University of Victoria, are designed around these principles. This figure is from a publication by De Silva that was published in 2011 called Helping People Help Themselves. It's a comprehensive review of self-management support research. And it is very interesting because it helps us really understand two different dimensions to understand self-management support. And so if I can walk you through this diagram, the arrow going across shows interventions that focus on information provision, so that would be patient education style, to interventions that focus more on behavior change, more of the self-management education, self-management support style. The arrow going up and down shows interventions that focus either on technical skills at the bottom or focus on self-efficacy or self-confidence at the top. Now, all of these types of interventions are important in a menu of options to meet people's needs and family needs and caregiver needs as well. But we know that information alone doesn't change behavior, so you cannot concentrate your efforts in the lower left-hand quadrant and expect behavior to change, for example. Every aspect of self-management support needs to be covered. So within an organization, you could think about a diagram like this and thinking about whether or not the approaches and interventions you're offering cover all quadrants of this particular model. Different clinical conditions may require different approaches. For example, diabetes has lots of technical components, like learning to monitor blood sugar or take insulin, manage diet or physical activity. A chronic condition like depression has more psychological components, and so some of the activities may therefore shift in this kind of an approach. But how does self-management support really work? So we've talked about definitions, and those definitions talk about things like knowledge, and they mention skills, and they talk about confidence. So knowledge means providing useful information in an understandable way at a pace that it can be heard and acted on. Skills refers to the ability to perform the activities that improve health, such as ways to manage medication, monitoring health conditions, maintaining and learning healthy habits. Sometimes it also means partnering with others to accomplish daily activities. Confidence is necessary to use the knowledge and skills. Without confidence, the knowledge and skills are not incorporated into daily life. A trusted caregiver can also benefit from attention to these three tasks in relationship to their caregiving role and as a way to assist the person they're caring for or to help themselves. So throughout the presentation so far, we've been using the word confidence quite a bit. So we're going to look at confidence in a little more detail now. Self-efficacy is another word that basically means self-confidence. It means people's beliefs in their ability to do things differently and affect what happens to them. The goal of self-management support has been stated as increasing confidence. Increased confidence alone is associated with better health outcomes, even in the absence of behavior change. Dr. Albert Bandura, whose quote you see here, is a psychologist originally from Alberta, and he studied self-efficacy beginning in education, also in behavioral health and in healthcare. And his thinking has influenced many people who work in the self-management field. Confidence is linked to the triple aim outcomes as well. So more confidence is associated with increased preventive behaviors and better disease control. So there we can get some of our outcomes in the triple aim. Confidence is associated with lower costs. Some of you may be familiar with patient activation and the patient activation measure. And it includes aspects of both skills, knowledge skills and confidence. And that patient activation measure is linked to cost of care. For people with low activation levels, they have costs of care that are 8 to 21% higher than the most activated patients. Countries like the UK have calculated that they could reduce healthcare costs by 7% overall if more attention were paid to innovative approaches that involve patients, families, and communities in more of their care. If increasing confidence is the goal, then helpers need to know how to achieve that. Dr. Bandura also described ways he thought that self-efficacy were increased, and this is in a very helpful classic publication by Drs. Kate Lorig and Dr. Hal Holman that appeared in 2003. And Dr. Bandura wrote that there are really 4 ways to increase self-efficacy or self-confidence. And we're going to look at each of these in more detail, but the 4 ways are skills mastery, modeling, reinterpreting symptoms, and social persuasion. The first one is skills mastery. So skills mastery means trying new things and achieving them. One example is when a person makes and completes an action plan of their own choosing. Bandura believed that this is the most powerful builder of self-efficacy. And here's the quote from Dr. Bandura in 1998 publication. A resilient sense of self-efficacy requires experience in overcoming obstacles through perseverance. This is a photograph of Joshua Bell, a famous Canadian violinist. He's a talented musician, but talent is honed through practice and feedback. He's practiced for hours on his violin to become a skilled master. Modeling refers to seeing someone like you doing something to demonstrate that you can do it too. This could be through video, through pictures, or having a group leader be someone like you. Hearing about another's experience can help build confidence. Another message that's helpful from peers is that these changes take sustained effort. Competent models teach skills to others and help them learn how to manage in spite of challenges, including the tendency to just leave things the way they are. Reinterpreting symptoms means forming alternate explanations for symptoms, like the diagram here. For example, an older person might believe that older people should rest. They remember their grandparents sitting a lot. And resting makes their muscles weak. Weak muscles can make a person feel more tired, which leads to the person feeling old and tired. Reinterpreting symptoms means they have a new idea. They have heard that physical activity could give them more energy. This can break the cycle. And the exercise or physical activity makes them feel stronger. Feeling stronger gives them more energy, and now they realize they could be an older person and be active with enough energy to do the activities that they want to do and that they truly enjoy. Reinterpreting symptoms is an opportunity to correct misinterpretations about physical symptoms and for people to develop control over the symptoms and situation. Social persuasion is the final item that Bandura wrote about that can increase self-efficacy. Social persuasion means encouragement and others' expression of belief in that person. For building self-confidence, we can structure situations in a way that brings success, and we can avoid placing people in situations where they're unlikely to succeed. Dwelling on deficiencies isn't helpful. People who have received positive reinforcement are more likely to keep trying. So we've just reviewed the 4 ways that you can increase self-confidence. It can be done through skills mastery, such as completion of an action plan, through modeling, seeing other people like us be able to do things, to reinterpret the symptoms, to alter what we believe about our behavior and what impact it has, and through social persuasion, that kind of gentle peer pressure to participate. Now, many of you may see that these are all things that can be very well done in a group, and this is exactly why self-management education programs are designed the way they are. Now that we've talked about these different ways to increase self-efficacy, let's just talk a little bit about measuring it. Since we believe that confidence is the target of self-management support, a really useful thing about confidence is that you can actually measurement. Here's an example, again, from Dr. Lorig and her colleagues. You could ask a question like, how confident are you that you can control any symptoms or health problems you have so that they don't interfere with the things you want to do? And you can see there's a scale there from not at all confident to totally confident. This is a simple scale that's used to assess a kind of overall sense of self-efficacy or self-confidence. It can also be done more specifically, like measuring whether or not a person can see themselves doing a particular activity or behavior. Measuring confidence can be used to help determine what kind of support people need and to track their progress on interventions. There will be an upcoming webinar on this topic. Now, we've talked about quite a few different concepts and ideas, so let's think back to Mr. and Mrs. Jones. We now have some other ways we could approach that situation. We can be thinking about the 3 tasks for self-management like we talked about before to make sure that Mr. and Mrs. Jones are able to work well and address those tasks in medical management, enroll management, and emotional management. We can make sure that we're focusing on building their confidence, and we can think about those things that build confidence. What kind of things can we do to help them be mastering skills? What kind of role models might there be for them? How might we help them reinterpret their symptoms in a different way? And what kind of gentle social persuasion might actually support them? Another way to think about Mr. and Mrs. Jones's care is think about stepping up that care. Now, when Mr. Jones was first diagnosed with high blood pressure many years ago, the first step in his care was advice for lifestyle changes. He was encouraged to increase his physical activity and to lose weight and possibly cut back on his salt. When his blood pressure remained high in spite of his attempts at a healthier lifestyle, the next step was to add a low dose of a blood pressure medication. So Mr. Jones took that medication, but his blood pressure was still high, so the dose was increased, another step in his care. After that step failed to create the desired drop in his blood pressure, another blood pressure medication was started. This is an example of step care. So Mr. Jones' diabetes care and his lung disease care likely followed the step approach as well, with each treatment tried and monitored for effect, stepping up the care until the desired result was achieved. We can also follow this approach if we think about self-management support. I'm going to show you an image here that was developed in an idea of out of that idea of clinical step care. And it has been refined through work with the Indian Health Service in the United States and here in British Columbia through Patients as Partners. The version I'm going to show you today was adapted from a Canadian publication that described the British Columbia approach. You can see that on the bottom of your screen there. The first step of self-management support forms the foundation of care that all people want and need. So here's our first step. And you can see this step is labeled. Step 1 is care that fits people's culture, that addresses diversity. It's also care that addresses health literacy and deals with engagement. We want people to be engaged in health. These are all mentioned in BC's framework for patient and family-centered care. These three terms may be a little bit new, so we're going to look at each in turn, and each of them will be the topic of webinars in the upcoming weeks. Diversity. There are many ways to talk about culture and diversity in healthcare. Culture influences the way people think about their health and their well-being and the ways they choose to manage it. Culture isn't just about ethnicity, it's about the many ways we've all learned to care for ourselves in our personal lives, in our families, and in our communities or social groups. The goal of being able to provide care that fits a person's culture can be called cultural safety. Cultural safety is one aspect of a person having a better experience of care, which is part of the triple aim. In British Columbia, the Intercultural Online Network, the University of Victoria Institute on Aging and Lifelong Health, the BC Patient Safety Quality Council, the First Nations Health Authority, every health authority, and many other groups are addressing culture and diversity. And there will be a webinar on diversity and self-management support on September 14th to cover this topic in more detail. So diversity is the first aspect of that first step. Health literacy is the second part of the first step. Health literacy can be defined as the ability to access, understand, evaluate, and communicate information as a way to promote, maintain, and improve health in a variety of settings across the life course. So health literacy is about finding, communicating, processing, and understanding health information for a purpose to make appropriate decisions and take action. This definition emphasizes the patient and family part of the conversation. There's another important component to health literacy, and that's the ability of professionals and institutions to communicate effectively so that community members can make informed decisions and take appropriate actions to protect and promote their health. And you can see these are from a Canadian publication, and you'll be hearing more about this in another upcoming webinar. Because some definitions of health literacy stop with the first definition, we think it's very important to look at both sides of the picture. After all, communication happens between two different parties in any interaction. It's both how the professionals and organizations present information and the abilities of the people receiving the information that determine health literacy. So this complete look at the definition is from this publication by the Canadian Public Health Association. Health literacy is a growing field, and emerging evidence and research has shown that low health literacy is linked to poor health outcomes, including higher hospitalization rates and less use of prevention services. It's also linked to cost, and as you can see, I'm talking about the triple aim here. In some literature, health literacy is noted to cost between 7 and 17% of all personal health expenditures and 3 to 5% of healthcare system expenditures. So addressing low health literacy helps create a more sustainable health system, a better experience of care, and better outcomes, all three parts of the triple aim. For residents of British Columbia, one example of a service that addresses health literacy is HealthLink BC, where people can access reliable, plain language health information and resources in their communities. The webinar on health literacy is going to be on September 7th. Engagement is the final part of the foundation for self-management support in the step care approach. So let's look at that item, engagement. And here we're referring to individual engagement, or when the healthcare professionals and patients and family members are interacting together. Here's the definition of engagement: the involvement in their own care by individuals and others they designate to engage on their behalf, with the goal that they make competent, well-informed decisions about their health and healthcare and take action to support those decisions. And if you're like me, you're noticing that all of these definitions are very closely linked, and indeed, health literacy, diversity or culture, and engagement are linked so closely together, they're often studied together. So engagement can be defined as a person's and their caregiver's involvement in their care. And again, the goal is making well-informed decisions and taking action. So if you think about this first step in the step care model, it can be considered as a prerequisite for self-managing the 3 tasks: medical management, role management, and emotional management. The webinar next week will be the webinar about engagement. So here's our first step again. And the step on the slides actually have 2 points of view. And you'll see the person and the caregiver's point of view represented on the left side of the step, and the healthcare professional or systems response is represented on the right. So where the healthcare professionals might be thinking about diversity, health literacy, and engagement, people might be thinking about working with someone who respects their beliefs and values, wanting to understand the words, and learning more about what they can do to help themselves. So let's go to the second step. And you'll notice that this step is smaller, indicating that not everybody will need this level of care, just like not everybody needs their clinical care advanced as well. Step 2 really talks about 4 key approaches that are found to be helpful in stepping up care. So these can be considered the core techniques to support behavior change as people develop as self-managers. This is the step that actually helps people who don't do it on their own take action on their knowledge. So if you think about the things that are written here: goal setting. Goals are outcomes that are determined by the person. Goals are things that people hope to reach several months down the road. And in many cases, breaking that goal down into smaller steps, which is action planning, can be very helpful. When the inevitable bumps occur along the road, deliberate methods like problem solving can be useful. Checking on the plan or following up on the plan increases learning. So those are the key approaches or techniques or interventions in the second step. So let's look at this in a little bit more detail. CCMI teaches brief action planning, which is a self-management support technique based on the principles and practice of motivational interviewing. Brief action planning is highly structured, meaning that it's easy to do the right thing because the evidence for effective action planning has been built in. There are many ways to help people make an action plan based on their goals. They're very similar because they're based on the same behavioral science. Brief action planning was developed for settings where clinicians tend to have briefer interactions, but they have relationships over time. It's since been used in many settings, including hospitals, emergency rooms, and community organizations. Brief action planning was designed so that peer volunteers could use it and that it could be used for telephone interactions. In British Columbia, all 5 regional health authorities and the First Nations Health Authority have committed to having brief action planning trainers to sustain and spread these skills within their region. Payne BC has incorporated brief action planning into their self-management support website called Live Plan B. A webinar on September 21st is going to provide more information and an overview of brief action planning. Action planning is also included in the self-management education programs at the University of Victoria. It's a key part of that program. So we have our second step, and let's build on the third step now. The third step captures advanced approaches that may be needed to help those people who need more than just those first 2 steps. So some examples here include motivational interviewing and additional support such as through care management or maybe group medical visits and problem-solving treatment, which is an effective approach that's been studied widely in depression and disability. All of the prior steps continue to be used. Most of the interventions at this step require clinicians learn additional skills. Motivational interviewing has been defined as a person-centered conversation style for addressing the common problem of ambivalence about change. It strengthens and builds on the person's own motivation and commitment to change. As you can see, this is from the book Motivational Interviewing, Helping People Change by Drs. Miller and Rolnick, which was published in 2012. Motivational interviewing has been studied for nearly 3 decades and has been found to be an effective way to help people resolve ambivalence and make a commitment to change. It's a way of talking and being with someone to support them. Some health authorities have begun to build their capacity for motivational interviewing by participating in a Train the Trainer program offered by CCMI. A webinar to provide more of an overview on motivational interviewing will be held on the 12th of October. So we're continuing to build our step care model. The 4th step is called specialized care, and this is for those who need more specialized expertise to meet their needs. And as you can see, the steps continue to get smaller, indicating that fewer and fewer people need that step of support. The expert methods include specific therapies provided by mental health practitioners and other professionals with specialized degrees and training. One of the Ministry of Health's priorities is to continue to improve care for people with mental health and substance use issues, including by integrating these services throughout the care system. There are factors, this level here is for those who require more specialized expertise, this specialized care. There are factors in the environment that influence people's health. This includes the environment that people live in, the support of family and friends, and the social determinants of health. You can see this represented by the light gray box around the steps. A webinar on the social determinants of health is scheduled for November 9th. There are some things all of us can do to improve the overall environment or the circumstances of people's lives, such as simple things like making sure they've applied for assistance or financial support. Many of the activities of healthy communities and things that you participate in are things that influence self-management by influencing the environment where people live, learn, work, and play, and supporting family and friends. The Family Caregivers of BC is one example of an organization with a mission to support family and friends as caregivers. So we have a step care model, and we have a situation we've been thinking about with Mr. and Mrs. Jones. So let's think about Mr. and Mrs. Jones and think about that step care approach. So how would stepped up care help Mr. and Mrs. Jones? They would benefit from receiving care that fits their culture, which a culture of an older person can be kind of passive, but also fiercely independent. You wouldn't know until you talk to them. We would invite them to be as engaged as they want to be, and because they desire that independence, we can work together on that goal through our engagement strategies. Mr. Jones' multiple chronic conditions and the possibility of memory loss mean that health literacy is a priority. Exactly how much information Mr. and Mrs. Jones want and need will be given to them to help them manage and prioritize the information and making sure it's clear. This can help them avoid future hospitalizations. Step 2, about goal setting, could be very helpful as Mr. and Mrs. Jones put their knowledge into action. This could mean taking small steps to try different ways to manage medications, to monitor their conditions, and to focus on what matters to them. Mr. and Mrs. Jones likely need advanced approaches. Healthcare providers can suggest organizations in the community that provide self-management support. They can incorporate motivational interviewing when ambivalence arises and suggest group visits or participation in self-management education. All of these would be appropriate for Mr. and Mrs. Jones. The professionals can also prompt further clinical care for depression and memory loss and partner during the diagnostic and treatment process. A referral to Family Caregivers of BC could provide Mrs. Jones with information, ideas, and support in her caregiver role. Mr. and Mrs. Jones may need those expert methods if the behavioral issues grow. The healthcare team can also assure that Mr. and Mrs. Jones have access to financial support available to them. Self-management support plays an important part in these 5 priorities in BC. As we've seen before, these priorities are about primary care access and primary care home, reducing demand on hospitals by improving care for seniors and improving care for those with mental illness and substance use, improving access to surgical services and procedures, and improving delivery of rural health services. So the way that self-management support addresses these could be that self-management support is an integral part of proactively managing chronic conditions. That's an important feature of the first three priorities. If we address people's primary care needs, if we help people with mental illness and substance use issues and improve care for seniors, we can really impact the kind of access and the demand on our system. When we use shared decision-making approaches, when people are fully informed about the possible risks and potential benefits of the diagnostic tests and procedures, people tend to make decisions that fit better with their values and coincidentally are actually lower in cost. So this provides opportunities to improve access to surgical services. Well-informed people choose diagnosis and treatment options that fit their personal goals. The step care model can also be used as a population management approach and to match the capacity of providers to the communities they serve. This includes rural and remote areas, creating clear guidance on who and how services could be provided. Now, we've gone through this webinar, we've talked about definitions, and we've talked about different ways you can think about self-management support, including the step care model. But one of the things you might be asking yourself is, does self-management support really work? Earlier, we talked about Deborah De Silva and her review of self-management support, and I'd like you to show you a little bit more from that review. Self-management support has been around long enough for a large number of research studies to have been published to help us understand how it works and what works. So this document is from the Evidence Center of the UK, and she reviewed 562 different studies of self-management support. Here's the quote from the introduction of that document. The literature shows that proactive, behaviorally focused self-management support designed to increase self-efficacy can have a positive impact on people's clinical symptoms, attitudes and behaviors, quality of life, and patterns of healthcare resource use. So if you think about the way that it's shown here, increased self-efficacy leads to behavior change and better outcomes. If we improve knowledge and have more self-management activities, that makes a difference in our care. Problem solving is key so that people can take action in new situations. Talks about improved quality of life. Clinical outcomes improve. So many things are improved by self-management support. So as you can see, self-management support isn't just a nice extra. There's good evidence that self-management support helps meet the goals of the triple aim. The evidence summary provided in this document actually supports a step care approach to self-management support, noting that tailoring to people's needs is one of the effective strategies. The evidence summary talks a lot about the different steps that work at the different levels. If you involve people in their decision-making, that's an intervention that works. Promoting healthy lifestyles and how to self-manage works, and helping people to monitor their symptoms and know when to take action. These are the things that are in the step one of the step care approach. The interventions that work in step two are the things we talked about: goal setting, following up, developing plans as a partnership with that emphasis on problem solving. At step three, the interventions that work include things that helping people manage social, emotional, and physical impacts of their conditions, like through approaches like motivational interviewing. That proactive follow-up that isn't left to chance, reaching out to people to see how they're doing. Care management programs are one example of this kind of proactive care. People benefit from learning from others like them, and this is why group interactions are so powerful. As you can see here, providing opportunities for people to share and learn from others is one of the evidence-supported ways to provide self-management support. So what we've been talking about today is the transformation of care in self-management support. And Dr. Tom Janice captured this perfectly in an image of a professional and a patient. And you have to imagine the patient being accompanied by their family and their caregivers. So a professional and patient who begin as being very separate people with the professional's needs primary, coming closer and closer together, experiencing changes in their roles until the interaction is really just between people working on a common goal. So in this webinar, because it's the first of the series, I've introduced lots of terms and many concepts that might be new. So the purpose of this was to provide definitions of self-management, self-management support, and to introduce step care self-management support and show how it's linked to the Ministry of Health's 5 priorities, the triple aim, and patient and family-centered care. I'd like to encourage you to learn more about self-management support by attending the upcoming webinars. You can see there are some documents that you can download from your control panel. And we'd like to open for questions and answers right now. So if anybody has questions, you can use the question box and we'll be monitoring those. And while we do that, I'll make sure you know about the next webinar. Next week, Dr. Kathy Rimes is going to be talking more about individual engagement. You will receive a questionnaire, a survey after this webinar. We'd very much appreciate your input to participate on that, to let us know how we're doing and what we could do to improve the webinars. And I'll continue to watch the question box, but I want to thank everybody for attending. Danielle, any other closing things for people to know about while we watch for questions?
Just a reminder that you'll be getting a link to the webpage where the recorded webinar will be shared. And if you want to forward your invitation to anyone else who you think will be interested in the upcoming webinars, that would be great. They just need to register and they'll have access as well.
Thanks, Danielle. Really appreciate everyone attending today, and thank you for letting me just continue to tell you lots of different terms and introduce you to many different ideas and concepts. I hope you found it helpful and that you join us in some of the upcoming webinars.
Connie, or someone has a question here. One of the callers is asking, what do you think some of the key barriers are to providing self-management support?
Oh, well, that's a really good question. I think there may be many different answers to that. And I think one of my thoughts about that is it's very similar, the barriers to providers doing self-management support is very similar to the barriers anyone faces making change. Many of us are very comfortable with the way we're doing things. It's familiar to us. And sometimes it's hard to imagine ourselves doing things differently. And sometimes it may not seem important to us to make a change, or we lack the confidence to make a change. So some of the strategies that we actually know can help patients and family members, people in our communities make health changes for their well-being are the same strategies that actually can help providers and healthcare professionals adopt new ways. Many of our healthcare systems, like Dr. Bodenheimer wrote, are set up in the acute care mode where we're not taking advantage of our ongoing opportunities to work with people in this way. And so there's many different things that can be done to support self-management. Thanks for the question. Appreciate that.
Just another question here. Mm-hmm. Did you see that, Connie?
Yeah, how can we address the real power difference when striving for a person-person relationship? Oh, this is a very interesting question, and thank you so much for addressing that. And I think I might think about this a little bit in the light of culture. The culture, especially in North America, has had a very differential power relationship between healthcare professionals and the public. And I think that is slowly evolving and changing as people begin to take more interest in their care and are not wanting to be treated in that way. So I think that it's slowly going to change, and each one of us has a part that we can play, both through our own interactions with our care providers and if we're in the healthcare system, how we design the system to actually promote that kind of an equal partnership. I think self-management support is one of the things that's going to get us there. I'm really, along with Dr. Bodenheimer, I really believe that this is asking for a transformation of care into collaborative ways of care instead of having people be at a different, being different from each other. So we did have some conversation coming in talking about how it's a really good self-reflection for providers to think about how they struggle with making change maybe in their work practices when they're dealing with patients or family members who are struggling to make change in their daily lives. And it's a very good and helpful observation. All right, so we will close the webinar. Thanks again so much for attending, and we look forward to your participation at the upcoming webinars.